Good afternoon, everyone, and welcome to this new seminar on COVID and HIV, part of the series of the Institute for Global Health Sciences on COVID. We have two fantastic speakers today looking at the interaction of COVID and HIV. We have Dr. Ellen Schell, who is a senior advisor at the Global Health Interfaith Alliance. And she's also an adjunct professor at the School of Nursing here at UCSF. Then we will have a presentation by Dr. Craig Cohen. He's a medical doctor, MPH, a professor at the Department of OBGYN, and also an attending physician at the San Francisco General Hospital, and finally, a co-director of the Institute for Global Health, UCGHI. So we have two main topics: how COVID is affecting our work in Africa on HIV, but also what are the opportunities given our HIV platforms for research in Africa to do work on COVID. So I'm looking forward to a great conversation and debate. Colin Boyle will be doing the moderation in questions. Please remember to post your questions in the Q&A icon when we have the presentations by Dr. Schell and Dr. Cohen. So, Ellen, may I invite you to come first, please?
Thank you. I'm just going to get my slides up here. Let's see. My slides seem to be stuck. There we go. All right. I apologize here. I'm having a little trouble making it go into slideshow. But maybe we will just
Ellen,
go ahead.
Go down below, you'll see the screen on the very bottom on the right.
Yes.
There
we go. There we go. Thank you. All right. So I'm Ellen Schell, and from 2000 to 2018, I was the International Programs Director for Global AIDS Interfaith Alliance, and now serve as Senior Advisor. So to tell you about GAIA, it's a nonprofit organization, and we work in communities that we serve to develop innovative and caring health programs in resource-deprived regions affected by HIV, tuberculosis, and malaria. And we rigorously test our initiatives and promote replication of successful models. We're very proud of our program of operational research, which seeks to continually improve the quality of our programs. And we have published from those studies. So GAIA has deep UCSF roots. It was started by the late Charles Wilson, Chair of Neurosurgery at UCSF, and the Reverend Bill Rankin. We are also very pleased to have the support of many UCSF colleagues on our medical advisory board, most especially Jay Levy, Haile DeVos, Richard Feacham, and Paul Voverding. Among some of the collaborations we've had with UCSF are a 3-year NIH-funded study on the response of religious organizations to HIV in Malawi with Sally Rankin. We've hosted 13 Institute of Global Health Sciences master students for capstone projects in Malawi since 2011, and we're currently hosting the HIV recency study in Malawi, George Rutherford PEI, and also the Global Action in Nursing Project with Kimball Schell is the lead on that. So an overview of Malawi. It has a population of 18 million in the landmass about the size of Pennsylvania. And you can see there's also a large lake that is part of it on there on the map. It's a young population, 46% under 15. It's also a rural population, 84%, but densely populated. And as you fly over Malawi, you can see this. You can see the villages dotted very closely together. So this means they have many ecological pressures, deforestation, and problems of that nature. Just for comparisons, Zambia has a population about the same size, but with 5 times the land mass, and it is right next door. HIV prevalence is 9.1%. And the country ranks 172 out of 189 countries on the Human Development Index. So it's got many economic and development challenges. For example, only 2% of rural areas are electrified. So the health system in Malawi, it's a government health system. It consists of a central hospital in each of the 4 larger cities. But especially if notable for COVID, there are only 25 ICU beds in the country and 17 ventilators. There are 28 districts, each has a district hospital, and each district hospital is associated with small health centers that provide basic primary care and maternity care. But in many districts, including the one we work at, there are areas where people have to walk an hour or more even to the closest health center to get care. So that is where GAIA comes in, and we work closely with the Ministry of Health as a gap filler, providing basic health services in those areas through a mobile clinic system, which I'll talk about in a minute. So GAIA has 3 main programs. They're targeted community projects. These provide support for youth, especially girls. It's keeping them staying in school, which I'm sure you all know is protective against HIV, as well as providing sexual and reproductive health education and services. And we also provide community-based HIV case finding and follow-up, and community-based information, education, and communication programs around health issues, especially HIV. Then we have a nursing scholarship program, which has been running since 2005, and we've sponsored over 500 students in that. We now, about 9% of the registered nurse workforce in Malawi are GAIA former scholars in our scholarship program. We have a service agreement with them to remain in the public sector for 4 years, and we're really pleased that now that we've been doing this for many years, 80% remain in the public sector, and 99% have all remained in Malawi post-agreement, because part of the whole point of this program was to replace the losses that had happened to HIV and to boost the nursing workforce in Malawi. GAIA has a mobile health clinic program, as I mentioned. We have 7 mobile health clinics. They are vehicles like you see pictured here. And the diagram that we have, you see what the clinic is like. It has 5 personnel. One is a nurse riding on a motorbike behind the clinic. She assists with the clinic in the morning, provides additional help when the big crowds come. And then she goes out afterwards to follow up on patients who need follow-up in their homes. For example, making sure that people who have tested HIV positive have gotten connected to the government facilities that get them initiated on treatment. The team includes a clinical officer, which is like a physician's assistant in the US, another nurse, a nurse aide, and then a driver. And each clinic makes a circuit of 5 villages. So they're in village A, for example, every Monday, village B every Tuesday, so people know where they are and when they're going to be there. And they provide basic health services, a lot of acute care around common illnesses like malaria and pneumonia, HIV testing, non-communicable care, where diseases care. We're seeing more and more people with hypertension that we're helping with there. And then also family planning services and health education and emergency transport for people who are very ill to the hospital. So here's a timeline of what's happened in Malawi with COVID. March 23rd, the president declared a national disaster. So schools and universities were closed, public gatherings were limited to 100 people, and screening at the border happened to foreign visitors who were then asked, all visitors were asked to self-quarantine for 14 days. On April 1st, the borders were closed and commercial flights were not permitted in. And on April 2nd, they confirmed the first cases and began initiating contact tracing. April 18th was planned to be a countrywide lockdown, but it was actually blocked by court injunction by a human rights group that said that closing down the country was going to cause such economic devastation in a country where many people are casual laborers or piece workers and really count on that daily wage to provide food for their families. So that still is, the country is still not in lockdown, though travel is very limited, severely limited. April 28th, the government announced a cash transfer program for 1 million individuals and small businesses affected by the COVID, but those funds have not yet started to flow to the recipients. Testing centers have been set up, and as of the end of May, there were 9 testing sites established. This is the National Ministry of Health website that is updated on weekdays. And as of now, there are 101 confirmed cases in Malawi. There have been over 3,000 samples collected and nearly 2,000 tested. So we're seeing a sort of positive rate around 3%. And what you can see here is that the southern area is most heavily affected. That's the area where GAIA works. And it's a little hard to see the little numbers on there, but as you might expect, the biggest case clusters are in Blantyre, which is one of the major commercial capital, and Lilongwe, about a third of the way up the map, which is the capital city. So what has been the impact on our programs? So starting with targeted community education and prevention programs, we've had to pivot to COVID prevention. And here on this slide, I am showing Joyce Jerry, who's in both photographs. And she's our wonderful nurse who is our country director, an extraordinary human being, and I think looks very fashionable in the face masks that we are having made. So what's happened here? A lot of our youth programs operate around youth meetings, which draw, hundreds of participants, clubs that meet regularly, and we've had to shut all of that down, which is really sad, but it has to be done. But we are collaborating with the district health offices on information, education, and communication. For example, the GAIA vehicles, some of them have PA systems which are getting used to broadcast information as they go through the villages about COVID and about protecting themselves, hand washing, distancing, and that sort of thing. We have a really wonderful donor base, and we were able to raise $5 million in the last month with a 30-day campaign to help keep our clinics in operation and also to help with things that are needed. So we're distributing 10,000 hand washing stations to households that are particularly vulnerable with an elderly person. So these are buckets with spigots, so people can wash their hands and distribute soap as well. And then we're having 25,000 of the locally tailored masks. That's what Joyce is modeling. That can be distributed and also used for our patients that come to the clinics. So the impact on our nursing scholarship program is that it's paused and we're uncertain exactly what's going to happen next. Of course, the campuses are closed, as I mentioned. Campus student housing is being commandeered for COVID-19 isolation. To the best of my knowledge, they haven't yet sent people there, but that's the plan. So that, because I think a lot of people, you know, if they have a mild version of the illness, will want to still go to work and to feed themselves. So there will be sort of wraparound supports in isolation to provide them with food and safety is the plan. There are e-learning is under consideration, but there's so many challenges because, for example, our students, the GAIA scholars who are receiving the nursing scholarship, they all receive on a need-based. And so while they may have a computer that they can use at their school, they don't own their own. And then furthermore, the connectivity issues in Malawi, especially where they're going home into their rural areas, are huge. So it remains to be seen what happens or when and if school will reopen. In terms of the mobile clinics, we're continuing with modification. And so, of course, the first priority is to protect staff with PPE. And you can see our staff here carrying on operations in their PPE. We're implementing social distancing. So typically when a clinic arrives in a village, we set up in an area like a church or a school that has been made available to us. And people wait outside. And typically on a typical day, a clinic may see 150 to 200 patients. So we have needed to teach people about social distancing and implementing that. We're also, of course, emphasizing hand washing and respiratory hygiene, setting up these hand washing stations so all clients will wash their hands before they come in to see a clinician, and masking of patients, especially, of course, with attention to patients showing up with respiratory symptoms. So additional strategies that we're doing are daily staff screening in terms of getting all the clinic personnel to take their temperatures twice daily and, of course, stay home if they're sick. We're adding staff to manage patient flow and enforce social distancing. So we're taking some of the people who are coming from other programs, like the community programs that we had to close down, to help with these tasks. Screening and segregating clients with respiratory or COVID symptoms. We're trying to conduct our services outdoors or in really well ventilated areas as much as possible for our mobile clinics. And we're working on setting up special hours for some services. So for example, patients who are just coming in to collect hypertension medicines, or women who want family planning, we can have special hours and times for them. And of course, observing COVID precautions, but at least trying to keep them away from people who are coming because they're feeling ill. Extending prescription refills. We do antiretroviral therapy at a few limited sites that we've worked out with the government, mostly at tea estates. And I know the government is extending refills for people for ART, or getting ART, especially if they're stable, for 3 to 6 months. So we're doing that, but also, for example, for the hypertension medication, just so that we keep people not having to come into the clinic so often. And of course, we'll support government efforts for contact tracing. So that's everything I had to say. And this is Zikomo, which is the Chite word for thank you.
Thank you so much, Ellen. That was an excellent presentation. I do have a question for you, but I will let Craig Cohen speak first.
Almost there. It does take a while. It's interesting. There we go. All right. So welcome everyone. Sorry I can't be with you in person. Thank you to Jaime and to Colin for inviting me to join you this afternoon. I'm going to be talking with you about the COVID-19 and HIV experiences in Western Kenya, where FACES operates. So I'll be introducing what FACES is for those of you who aren't already aware. Talk a little bit about COVID-19 in regards to HIV infection, but mainly focus on implementing the HIV care and treatment and prevention program, which is what FACES is, during the era of COVID-19, lessons learned, and then future implications and potential thoughts on collaborations and shared learning. So FACES is a collaboration between UCSF and the Kenya Medical Research Institute. We work very closely with the Kenya Ministry of Health in Kisumu County. It's led by myself and Elizabeth Bakusi, who's a world-renowned researcher at KEMRI, and Dr. Frankie Odhiambo is our esteemed director. She's an internist, internal medicine physician, and been working with HIV care and treatment for over a decade. This is a brief timeline. We don't go as far back as GAIA, and GAIA has done amazing work in Malawi, again, in connection with UCSF over many, many years. We go back to 2004 when PEPFAR was started, and where we wrote our first grant, what we call FACES 1.0. In 2004, we started with 2 sites, a site in Kisumu, and then also 1 site in Nairobi. We then, currently we're in FACES 3.0, which started in 2016 and ends in 2021. We have also, in addition to providing care and treatment and prevention services, we also serve as a platform or foundation for probably over a dozen clinical implementation science projects, most of which are linked to UCSF and to KEMRI and are led by about a dozen faculty and fellows at UCSF with their counterparts from KEMRI. Just around geography, for those of you who have not had the opportunity or the pleasure of going to Kenya, it's one of the main countries in East Africa. Population has 42 counties. So we work in Kisumu County, which is one of the 5 counties bordering on Lake Victoria. Kisumu is the 3rd largest city in the country. It's predominantly a fishing population around the lake, population of about 1.1 million people. HIV prevalence is, per county is 2nd at 17.5%, where nationally it's about 5%. Over 122,000 people are living with HIV just in Kisumu County alone. And through our partnership with FACES and working very closely with the Ministry of Health and support from CDC and other partners, about 90% of people living with HIV are currently receiving treatment. So FACES, again, we're predominantly an HIV care and treatment program with about over 50,000 people currently on antiviral therapy. So to put that in context, it's over 3 times the number of people living with HIV than San Francisco County. So including, and with about 95% viral suppression overall. As I mentioned, we have over 20 or 24 research grants that are implemented, funded by a variety of donors, including NIH, Gates Foundation, CDC, and other foundations and private philanthropy. We've trained more than 150 students, most of whom are trainees, most of whom have come from UCSF, either as students or residents and also fellows, but also from other North American and Kenyan institutions as well. So COVID-19 the discussion started in Kenya towards late February, actually started in January when I was there. And immediately in discussing with COVID-19, I was starting to understand and having a discussion with my colleagues in Kenya at a meeting in Nairobi that this was eventually going to be coming to Kenya. And what could we do collectively or collaboration do in order to help prepare Kenya for this inevitability? So what we've been hearing about in the media, and for those of you who follow the Johns Hopkins website or WHO sites, is that we're seeing an increasing rise in the COVID-19 disease spread and the virus spread in Africa, with over 64,000 people now confirmed cases, a fatality of about 1,800 people. And if you look at by region, East Africa is the light blue portion. It's still the smallest proportion by region in Africa, but it's difficult to tell because of the scale, but it is continuing to increase in East Africa. West Africa, for reasons we don't fully understand, has been hit probably the hardest in the region, followed by Southern Africa, which of course that includes South Africa, which has the greatest number of cases on the continent. This is as of May 19th, so it's already about a week old, and I'll give you some brief updates. But Kenya had confirmed almost 1,000 cases, including 50 fatalities. You can see the map of the country where the majority of the cases are occurring in Nairobi. That's that larger red circle in the center, southern center here, followed by Mombasa. That's where the majority of the cases are. And Kisumu County is this white region here, meaning that as of 19th of May, there were 0 confirmed cases. However, on Saturday, Kisumu confirmed its first 3 cases. 2 truck drivers were identified. Kenya is screening truck drivers at the border. And then there was a woman who was part of a funeral party going from Nairobi to Kisumu and was identified and then has since returned back to Kisumu for isolation. Also note that 79% of the cases are asymptomatic, and that's because Kenya's done an excellent job of contact tracing. So when they identify the individual who's infected, then they will go to all of their contacts over the prior 14 days and identify those people. Some of those people are infected, of course, but the majority or high proportion of them are asymptomatic, at least at the time of their initial diagnosis. Interestingly, when people have been talking about COVID-19, people have been talking about the gender imbalance. And similar to what's been found in other countries, including here in the Bay Area, we're finding that men are making up the majority of the cases, 76%, in comparison to 24% of the cases amongst women. It's still unknown why there's this gender disparity or sex disparity based on sex. Deaths, 30% of the deaths have happened in the household, majority from Mombasa. 100% of those who have died have had comorbidities. And then also, if you notice the distribution by county, again, in regards to age distribution, there's a higher proportion of individuals in the younger age group, so 60 and below, that are being affected by COVID-19 and deaths. But part of this obviously would have to be corrected for the age distribution, because like most countries in sub-Saharan Africa, you have a kind of a Christmas tree variation for age, where you have a lot of very young people and very few older people. So it would be interesting to know these data on mortality based on proportion of the population in each age band. So it's really not known yet. We have very little data so far coming from the field, understanding if people living with HIV are at increased risk of infection, and if they're infected, do they have a different clinical course than those people who are uninfected? There are a few cases reported from China. I think we'll be getting more and more information on this very important question, especially coming from countries like South Africa, that has a high number of people living with HIV and also COVID-19 cases. And then it can't be inferred if the immunosuppression that we know is it puts people at risk in general for severity of disease may also play a role in people living with HIV, especially in the case which I showed you at least here, where you have 94% of people who are virally suppressed and obviously who are living with HIV. So early on in the emergence of the epidemic, we were, and again, as Jaime mentioned, I do work at Zuckerberg San Francisco General. We were starting to make a lot of decisions around how around which patients we would see at the clinic on 5N at ZSFG. And we decided to decompress the clinics for twofold reasons. One was to decrease the risk of transmission amongst patients waiting to be seen or being seen at the clinic. And number two, to reduce the exposure of health workers. So both would then, so if we were successful, we would decrease the impacts of the epidemic and allow the healthcare sector to be able to take care of people with COVID and also without COVID. So immediately we started having discussions with our colleagues in Kenya about this sort of approach to decompress the clinic. At the same time, the Kenyan Ministry of Health was starting to put out some guidance documents as well. So we started developing a plan, and we were also concerned about potentially looming ARV shortages as supplies, the movement of supplies within the country and to the country could be adversely affected by the COVID-19 pandemic. We immediately started to curtail the community-based portions of our program, including HIV testing, defaulter management, and adherence support for those failing treatment, and moved to non-physical ways to be able to conduct adherence testing and defaulter management. These are, as I mentioned, the government started putting out and continues to put out supplements to their emerging national guidance on COVID-19 and HIV service. Some of these follow also from what WHO recommendations, as well as specific recommendations from PEPFAR, which funds the FACES program. In addition, there's been increased information going out to communities within Kenya, including the rural communities, which is the majority of the places where FACES operates. And interestingly, I don't have the data, definitive data, but I think that the penetrance of this sort of information about COVID-19 has been so rapid that probably about 90% of people 15 years in age and older in Kenya are aware of COVID-19 and some of the basics regarding transmission and how to prevent transmission of the infection and what to do if one's been exposed. So the Kenyan MOH guidance was really put in place to ensure the continuity of HIV service delivery. Again, HIV is essentially a chronic illness and requires some level of continuity of care within contact with the healthcare facility and also receipt of antiretroviral therapy for at least patients who are stable, a more acute level of care for those patients who are having challenges with viral suppression or other issues, comorbidities such as hypertension or mental illness, etc. So the government put in place to provide an additional 3-month supply of ART for all people living with HIV, regardless of their age or viral load status. So Kenya had been rolling out differentiated care models to provide 3 months worth of supply to patients living with HIV who were stable and met prescribed guidelines. But this got extended to all patients, and including patients who were newly diagnosed, adolescent patients, patients who are pregnant and living with HIV as well. And that facilities should promote flexible ART delivery models such as community ART group distribution with staggered pickup times and pharmacy-only visits to healthcare facilities, etc. So we started to put those guidelines into place very early in late March. So very early, this is when Kenya had no confirmed cases actually, because we knew that it was coming. We predicted it was coming. And then we already started to implement staggered clinic appointments. We started to provide clinic appointment times, not just days, because typically in places like Kenya, patients tend to congregate very early in the morning and it's first come, first served. We wanted to move out of that construct into an appointment facility or appointment times to actually spread out the visits that patients would come and be waiting in the waiting area. We also changed our waiting areas to be more outdoors and to decompress those areas too. Flexible ART delivery, screening and isolation of symptomatic patients, similar to what's been done for a long time for patients who have TB symptoms. Temperatures are taken at arrival. Screening for other COVID-like symptoms are also performed right at arrival to the clinical facility or at the gate. Health education sessions would happen similar to what we saw in Malawi. This would be done outdoors with physical distancing. And then I'll be talking about this a bit more. We started to implement and scale up mHealth applications. Ushuari, it's a way to communicate using a text-based format with our clients. About 80% or 85% of our clients have a cell phone and cell phone access, so we're able to push information out and also receive questions from the field, including most of the patients who came in for the additional 3 months of treatment of ART were told to come in through the Ushuari format. So we didn't go out and physically find them, but we actually pushed it out using this text-based format. So this is to give you some data of an evaluation that we performed. We wanted to see what was the impact of implementing these guidelines within a very short period of time. There's really a dearth of data and understanding currently how the COVID-19 pandemic has affected people living with HIV. And we wanted to be able to demonstrate a scalable, very resource not intensive method, and to see if this is something that other programs and other counties could take up either in Kenya or beyond. So during the pre-intervention period of March 20th to 23rd, we saw a total of over 26,000 patients. 26,000 patients were contacted, 96%, who had their next appointment prior to April 30th at the 60 supported phases sites and asked to come in for a refill. Of those that were expected, 85% of those who were expected to come in for an early refill came in by April 2nd. So you can see that's less than about a 10-day period of time. We were able to get 85% of that population in for an additional 3-month course of ART, working towards decompression of the HIV clinics. And what we found is that during the baseline period, March 9th to 13th, and the post-intervention period of April 6th to 9th, we can see that average daily attendance overall at all facilities decreased from 1,298 per day to 640, over a 50% reduction in the number of patients coming per day. The decrease was greater in our larger facilities. These are facilities that see 1,000 or have 1,000 or more patients enrolled in HIV care and treatment, in comparison to the smaller facilities with about a 33% reduction. So, our program also provides a lot of HIV testing for Kisumu County. Again, we've identified 90+% of the people living with HIV in the county. When I say we, the Ministry of Health, the other programs, including phases. So we had to stop our community-based HIV testing for obvious reasons, and focus instead on prioritizing the clinic-based HTS for antenatal care, diagnostic testing in certain areas of the clinics, early infant diagnosis, and then partner and family testing, which is really a passive testing methodology that we use to identify the remaining people living with HIV who are not yet in care and treatment. And then continue with linkage, but shifting from face-to-face counseling to more remote linkage using cell phones. And then we had to suspend all voluntary medical male circumcision following the directive from the Ministry of Health. So we learned that this approach, which actually was able to be implemented within about a 2-week period of time, the team in Kenya developed the methodology, working with the Ministry of Health colleagues. We were able to significantly decompress the clinics by over 50%. And we were able to continue most of the services. And this way it enabled and still enables the clinic staff to be able to focus on the highest priority patients for in-person visits in clinics that are decompressed. It reduces the spread of COVID-19. So these would be the patients who are newly enrolled in HIV treatment, HIV-infected pregnant women and breastfeeding women, clients who remain viremic, and children and adolescents. Although the older adolescents, we've also moved to the model similar to what I presented here as well. So we hope that this has enabled the healthcare workers to be able to cope, improve their coping, to be able to deal with the patients living with HIV, and then allow the potential to have the increased ability to take care of patients who present with COVID-19 symptoms. That I showed you earlier, Kisumu just identified its first 3 individuals with COVID-19. We don't know how that what this will lead within Kisumu County. There are other surrounding counties also with numbers of infections in the single or small double-digit numbers as well. So our concern collectively is that the response to the COVID-19 pandemic in Kisumu and regions like Kisumu, which are predominantly rural, although we have, again, the 3rd largest city as well in Kenya, is likely to affect those who are at the lowest socioeconomic classes the hardest. Because, as was mentioned earlier, these people who are employed are usually employed as day laborers. They work a day, they get paid a day, they eat that day or that night, including their families. If they do not work, they do not eat, and their families do not eat. So we're very concerned, and this has had a major impact on the response has had a major impact on transportation. Although Kenya is much better endowed in regards to health facilities, many people do, if they're not walking distance, then will rely on public transportation, motorbikes and matatus, vans, shared vans, in order to get to the clinic. We do need to rapidly harmonize the emerging information on the resources, the guidance, and the support coming from the government, but also meet the needs of our patients. And we need to work with the stakeholders, especially at the county level, but also within the various communities. And really, as HIV has shifted to a chronic care model, we need to see how this can be extended to other chronic health issues, such as non-communicable diseases, hypertension, diabetes, et cetera, and also take care of women and children. So women who are pregnant and postpartum, and also children during the early years of life. We still need to develop indicators on what is the impact, not just the health impact of COVID-19 of people living with HIV, but how might the response to COVID-19 affect people living with HIV? Is it possible that people living with HIV, and other people as well, avoid going to the healthcare facility because they're afraid of COVID-19, don't pick up their drugs, they don't have access to getting their drugs, and then end up getting severely ill or even dying of HIV, not because of COVID-19 or because of anything due to their health per se, but because it changes their behavior. And I think we have to be cognizant of that, as well as mental health issues, food insecurity, which is rampant in Western Kenya and even growing under COVID-19, in part due to the lack of transportation and on the workforce. So we are starting to work more closely with the government. We're certainly working very closely with the government in Kisumu County to look at some of these issues, and potentially be extending some of this work to other regions of Western Kenya, potentially working with the Population Council. And I have a call later on this week to talk about these sorts of information, getting them from the population themselves, that the country, the government, the policymakers so dearly need in order to make the best decisions for their people. I also want to give a shout out to IGHS. As you know, we've been having these sorts of discussions around the impacts of COVID on our work collectively. And about a month ago, I joined one of them. We were talking, and I met Reena Gupta, who happened to be, when she was a resident, spend a month or two working at FACES. And we started talking about telehealth as a potential solution to overcome some of the challenges around continuity of care during the time of COVID. And on Friday, she and I, along with Starlee Shade, Elizabeth Vakusi and Frankie Odhiambo, and then Purba Chatterjee and Jane Kulzer, we put together a supplement which is being submitted as part of the Center of AIDS Prevention Studies to NIMH to expand telehealth. Reena has years of experience of working on telehealth solutions, mainly in regards to NCDs. So we now want to extend this into HIV as a model, and we put together a design for a cluster RCT as we try to shift people to telehealth. And it's not just, we're using the excuse of COVID, but also, as we are seeing here in the US, telehealth is expanding, and it's expanding within ZSFG and also many other healthcare systems, we want to see in a low-income setting if it may be a more cost-effective model to provide high-quality HIV care and treatment to the population. So I want to thank my colleagues, Frankie Odiambo, the country director, long-term friend and colleague Elizabeth Akusi, Purva Chatterjee, and Jane Kulzer were the core elements of the FACES team, and all of the people that have made this possible. Thank you.
Thank you, Craig. And thank you, Ellen, for very, very interesting presentations. I have a question for you both. There's an article in The Economist essentially claiming that for Africa, the measures taken in the rich world do not apply to Africa, and that the remedy might be worse than the disease, and the impact on the economy will be far worse than the epidemic itself. Can you comment on that? Ellen?
Yes, well, I think that's exactly what happened in Malawi. You know, when this the initial move was by the president to go ahead and try to start my video. It's not happening. To go ahead and shut things down, and therefore there was this protest from this human rights group, as I mentioned, and I think it's a very real issue. When people can't work, they can't eat, and I think it can have myriad kinds of complications that we are only just seeing. Here you see people talk about people working from paycheck to paycheck, but it's day to day for so many people, and particularly in Malawi. And there are other kinds of consequences too. For example, Malawi was hit by very bad floods, parts of Malawi last year after the cyclone. And people were counting on being able to sell their food so they have money to buy food in the dry season. And they have no way to replace that if they can't get out for piecework or do that kind of thing.
I mean, so I've had a lot of discussions with colleagues and with friends around this issue, including my friends in Kenya, and I would tend to agree with the Economist's perspective. But again, these countries are not homogenous either. Nairobi, a bustling city of 4+ million people, with some very densely populated areas, versus parts of rural Kisumu that have a much lower density. So I think some level of, I'm kind of thinking like the Swedish model, although we don't know how this is going to pan out yet in Sweden either, certainly. But you know, in the end, what is it we're trying to accomplish? We're trying to preserve life. And so these are very difficult things to be able to model, right? Because you're looking at the effects of COVID, the effects of HIV and NCDs and other maternal health issues, but you're also looking at things like food insecurity. You're looking, and then there's the issues of floods, which Western Kenya has been undergoing series of floods and droughts. It seems like that's all that happens, and which leads to greater food insecurity, right? And then the lack of education for our children and their children, how that is going to impact during this next generation, we don't know. So it's very complicated, but I think that solutions should be, I don't want to sound too Trumpian, but they should be local. So even within Kisumu County, there's the urban center, right? And then there's the more densely populated slum areas, is different than in the farm areas, I would say, where people are spending during the daytime, majority of the time outdoors. But perhaps large funerals are not a good idea right now. And those are very common in both urban and rural ideas. Perhaps large church services with the lovely singing that we all enjoy is probably not a good idea right now. So I think coming up with sensible solutions, and you need to get the buy-in of the local communities and local community leaders, is what's going to make the most sense and will help to bring the community together to be able to address COVID and all these other hardships that the people in these regions and our own country are dealing with.
Colin, may I turn to you?
Yes, thank you, Jaime, and thank you, Ellen and Craig. Appreciate it. Just an invitation to audience members to feel free to submit any questions you have in the Q&A box on the bottom. One question for both of you that I have in light of what you just said, Craig, which is the potential need to implement a set of changes to religious practices, funeral practices, and the like. I'm wondering if the two of you can comment on how the population's experience with HIV and the HIV epidemic across Malawi and Kenya is likely to affect how they view public health orders in this pandemic. Obviously, in the US, we've seen quite of a mixed response to public health actions. And I'm wondering if you have any comments on how the populations in the countries where you work will receive directives and suggestions and guidance from public health officials.
I don't know. I think in Malawi, because of the experience with HIV, and also because of knowing about the experience of other countries in Africa with Ebola, for example. I mean, I think they ramped up their protection for Ebola. They were worried about it. People paid attention to it. And I think they really, it took a while for people to, especially out in the rural areas where people didn't know much about HIV and there were myths and all kinds of things and so much stigma. But what really, especially once treatment became available, people really understood, yes, there are things that can help us. And you saw the chiefs get on board and they started to welcome programs coming in to educate them. And I mean, I think Malawi, for a very under-resourced, very poor country, has done a remarkable job. I mean, hopefully this won't throw us off, but they're on track to meet the 2020 and the 90 goals in 2020. And I think it's sort of a testimony to what can happen. I think the very high value people place on community in African countries is really helpful because there is a real sense of the common good. So people will listen.
Yeah, I would really agree that it's what we've been sensing in Kenya as well. The other thing I would put out too is that HIV and the response to HIV, especially in regards to training, has really created this amazing class of individuals within the Ministry of Health, but also with partner organizations like CDC and so forth, to really rapidly deal with COVID-19, I would say in a much more unified way than in our own country. And even if you take a look at the daily briefings from Kenya, of which I partially use in order to develop my proposal, they appear to be transparent, clearly laid out in a lay language, but with enough details for the experts to be able to act accordingly. The press releases by counties, Kisumu County put out, the infections were on Saturday. On Sunday, they had a press release spelling out exactly who these 3 people are, not naming them, but truck drivers, they're isolated on the isolation ward at the county hospital, et cetera. That level of transparency is not what we're seeing here. And I think, but that preparation, I think, in part is because of the amounts of resources and training capacity building, of which UCSF has taken a part in, have come about and brought about to help these countries.
Sorry about that. Another question. You mentioned in the course of your remarks a number of practice changes that are being undertaken to help de-densify clinics and the like. You mentioned community distribution of ART, 3 months or 6 months of dosing, telemedicine, mHealth appointments, the different way of operating. Do you anticipate that those changes will stick after the pandemic?
I personally do, and I'm really excited to. It was also interesting, I should say, that the proposal that we put together with Rena and with Starley and Elizabeth and so forth, we did it entirely virtually. So Rena and I haven't met except for on the chat room that you put us in randomly. We've been working together, over the last few weeks, 3-4 weeks, on this proposal, along with our other colleagues, and we submitted it with RMS, UCSF, And hopefully, maybe we'll even implement it without ever being in the same room. It's possible. So it really points to the possibility of shifting to more telemedicine. I became very aware of it by working at ZSFG just in the past few months. There's so many of our patients that come in to get results that are normal, or for follow-up to find out, how is the treatment working? Yes, I'm better. That I would say in San Francisco, they don't need to spend their time, their resources, nor the facility resources or our time to actually come into clinic. It could be a short telephone visit or ideally video visit. So why shouldn't patients in Kenya who increasingly have access to high-speed internet, smartphones, to be able to have that same luxury? And also with PEPFAR dollars and donor dollars going down, we need more efficient models to be able to continue to expand high quality care. And I would say that providing telemedicine can be, we have to prove it, and that's why we propose this cluster RCT as an implementation science project. But we need to prove that. But if our assumptions are correct, then why shouldn't this be one of the solutions that gets scaled up? Health facilities are even without COVID, are too busy. Healthcare workers are overwhelmed. So healthcare workers could be centralized into certain pods to be able to use telemedicine, or even from the comfort of their own home when that makes sense.
Ellen, do you have any comments on that? Any reflections on what might stick after the end of this?
I agree. And our wonderful Director of International Programs, who succeeded in my position, Beth Jeffroy, says that we should be learning from this to improve our programs in the future, that improvements that we're making now are things that can really help us going forward. So I have a positive outlook on that. And I have to say that, as I was hearing friends complaining of the difficulty of working this way in other kinds of jobs who weren't used to working this way, in a way we were ahead at GAIA, because at least on the administrative front, we work very closely with the Malawi organization. We've been working this way for years, and it was a sort of a leg up.
Yeah, one final question for you. You've both been on the front lines of building capacity in these countries, really kind of developing and training the next generation of leaders and clinicians. And I'm wondering, in this country, health workers right now are heroes, celebrated in the media and in the popular public's view. And at the same time, in certain places, I think there's often a stigma attached to them around an infectious disease, where they're actually seeing the people who are suffering from that disease, where they might be seen as vectors of disease. I'm wondering if you can comment on any stigma you're seeing in these countries around the health workforce, and whether that's any efforts that are being undertaken to combat that.
I can only report on one, something our country director told us, which is that nurses who you were used to going to the climbing onto a minibus to go to work in their uniforms are no longer doing that, because there was the instance of a nurse getting thrown off of a minibus, because people didn't want her there; they were afraid. So I think it's there. I'm not hearing huge, that it's massive or problematic, but that's what I've heard.
Yeah, I'm not close enough to the ground literally right now to know detailed stories like that per se, but I do know that FACE has made working with the Ministry of Health, made a very early policy decision that we want to protect our healthcare workers, all healthcare workers, and that's part of the rationale for the decompression. We also believe we are doing it to protect our patients as well, and that we can continue to provide high quality care without having people come to the clinic as often as they're used to. So we're working hard to protect our healthcare workers. We've done many other things in regards to hand washing and PPE and so forth, that I'm not going into those details as well for this presentation.
Thank you both. Appreciate that very much. Jaime, back over to you.
Thank you. I have a 30-second question for you both. Do you think that testing is a limiting factor in Africa to really track the epidemic?
I was very interested in the editorial that came out in the Lancet that talked about the importance of testing, and the countries that have managed to do population-based testing of at least 1% random testing to look at COVID and how important that's been. And they're making the point that because of what's happened in so many African countries around HIV and HIV testing, that we have the mechanisms in place to do this. We kind of know how to do this because we've already done it. So I think we should forge, I hope Malawi forges, their government forges forward with that.
I think, and I'm not an expert on this, but I think Kenya's done a commendable job in regards to scale up testing at its major laboratories, so in Kisumu, which is part of CDC, and Nairobi and Mombasa. And then to be smart in who they're testing. So contacts of identified cases, and then they're testing people at the border. So these are the truck drivers. And then Kenya, probably like Malawi as well, shut down its international airports, at least for this period of time. So there aren't travelers coming in from other countries right now. So I think they're really trying to limit the spread of infections through the contact tracing. And overall, I think they're demonstrating their overall success, but we need more time to see if that's going to be the case.
I would like to thank you, Dr. Schell, Dr. Cohen, for your splendid presentations, and look forward to have all the attendees join us for the next Tuesday COVID series that will be on COVID and maternal neonatal child health. Thank you all, and goodbye. Thank you.
Thank you.